Hi everyone. So I'm kicking off and then I'll be handing over to my colleague Rob Trubey. So we are researchers with a particular interest in routine data at the Centre for Trials Research at Cardiff University. So for those of you who might not be familiar with the trials unit, we are a large department. I think there's maybe 150 plus members of staff now. And the directors of the department are Richard Adams and Mike Robling. We have 4 divisions. So we've got brain health and mental well-being, infections, immunity and inflammation, cancer, and then if the research doesn't fit into any of those, then we also have population health and social care. So we cover a large range of research, trials, feasibility trials, but also other sort of well-designed research projects and to support other researchers with their ideas as well. So that's who we are. And so within that, we have a routine data team, a routine data strategy, and we've got a lot going on in this space. We've got more than 10 PhD projects now, 40 active studies that are using or thinking about routine data in some way, whether that's assessing feasibility, looking at acceptability, PPI work, as well as then actually using routine data as part of our trials. We work with a lot of groups across the UK to sort of enable this this research. So we've been on a journey. We're still going on a journey in this space. And I think probably back in 2012 is where I'll be starting the story. But what we've been doing is sort of expanding our area of expertise and knowledge in linking routine data for trials, for trial outcomes in particular. And then Rob later on will be talking about sort of where we are currently and where we'd like to go to in the future. And this is really just to sort of give you a lay of the land of what is currently possible within the sort of the trials area, but also sort of where we hope to get to soon. So starting off with the building blocks trial, this was, so it was published in 2016, but I think possibly started 2012 or even earlier, led by Mike Robling. And this was a large randomized controlled trial. And what I'm focusing here on is basically how we've used routine data in these projects. So I'm not going to go into a lot of detail about the actual trials or the results, but please do have a look at the papers. So as part of the building blocks trial, we, Mike and his team, recruited mothers and their children to take part in a nurse-led intensive home visitation program, the Family Nurse Partnership. And as part of their follow-up for the 2 years following receiving the intervention, they were linking to hospital records via NHS England, now known as NHS England, but also access data from GP records through individual, sort of contacting individual GPs to ask data on their participants, as well as linking to the national abortion statistics. So that's where we sort of really started with saying, okay, this is really possible. This is a really nice way to get some of our secondary outcomes with the trial and sort of being able to follow up those participants without specifically asking them about abortions, for example. And thinking about trials and in particular population health and social care trials, there is often a need to have some objective outcome assessment. If you think about children's social care, those who are most likely to be in receipt of children's social care services are the least likely to be saying that if we were to ask them prospectively. So being able to link to information about these individuals, we get a non-biased perspective on those outcomes. And I think the other thing to think about is that often these interventions are very complex. And although we may have an idea that this will definitely impact someone's health outcome or something very specific, actually the impact of an intervention is likely to affect more than just one small part of somebody's life, and actually then if it's about children, then there might be an impact on their education. As I've mentioned, there may be interactions with social care. So there's, everybody's life is changing all the time, and I think being able to capture some of this through routine data is a really nice way to sort of get more of a comprehensive picture of what's actually happening with this intervention for these individuals. And so at the end of the building blocks trial, we then continue to follow up the same cohort of these mothers and children for another 4 to 5 years. And so we use an opt-out model for this part of the follow-up, and we are able to link these individuals to their health records, education, and children's social care. And we're able to then look to see how they were getting on as the trial had concluded, and we were able to do that without going back and asking prospectively, how are you getting on? And we're able to get more of this objective view. So that's one of the sort of real benefits of what we've been able to do. And then this has led to other trials in especially children's social care space. So more recently, Dave Westlake, who's part of Cascade in the School of Social Sciences at Cardiff University, led on the largest evaluation of a school-based social work intervention in the UK. And we use routine data for all of our impact evaluation. And again, the publications are on the screen. It was funded by the What Works for Children's Social Care, as they were known at that point. And we actually started from a top-down approach here. So we recruited local authorities who then identified schools to be randomized, and then that encompassed then 280,000 students who we were able to then get aggregated data from the local authorities held routine data sources. So in particular on the children's social care, we asked local authorities to provide us with summary information at a school level of these children at these schools who were receiving intervention, which was whether or not having a social worker based at a school was of benefit compared to a social worker based in their local authority office. So that was another way of doing things that wasn't linking at an individual level. We were sort of starting at the top and then getting aggregate routine data, but another sort of example of what is possible for routine data in trials. Rob, over to you for this slide, please.
Yeah, thanks, Fee. So Tiptoe is an ongoing clinical trial that we're managing in Cardiff, a very large trial funded by NIHR. It was a randomized controlled trial looking at a self-management intervention for older adults who live with knee or hip osteoarthritis and other morbidities. And I think the team in Cardiff came to us quite early with this one. They had kind of a clear kind of logic model about how they thought this intervention would work. Essentially, they think that this kind of self-management approach will help people manage this condition, reduce pain, improve quality of life, but also kind of reduce the need for acute care and complications arising from that. So as with a lot of trials that we are now running in the unit, this is a kind of hybrid approach where there's some direct data collection from the team and some kind of routine data as well. So in this instance, we're linking with secondary care data sets. Both this is kind of run in England and Wales, so we've got NHS England, HES data, and SAIL, and ultimately that data will be combined in the SAIL TRE. And I think one of the things we did quite a lot of work on here in this instance was early on we have a kind of large PPI group with this trial, and this is a kind of an ongoing interest for us is how we develop kind of good consent and information materials for the public when we're doing routine data trials. So obviously NHS England and SAIL have sort of things that they need to see on consent forms in terms of transparency. But when we work with the public, and in this instance, our kind of average age of participant is kind of late 70s, early 80s. So we put quite a lot of time to thinking about how we develop kind of clear materials that tick those boxes, but are also kind of accessible and transparent for people. So as well as just kind of a standard information sheet that we might use. We have videos, we have kind of summary leaflets, easy read materials, but all of those, we kind of had to put a lot of thought into how we'd explain the proposed kind of linkage method. So quite a simple trial in terms of the kind of data flow, but lots of considerations in terms of how we develop the consent materials for this.
Thanks. And so over the sort of 10 years plus of working with routine data, we've learnt a lot, and we've also linked in with trials units across the UK who are also having similar learning journeys, in particular around the governance and the data application process of accessing these data for trials, even where there is consent. And so sort of coming out of these initial conversations, then these larger organisations such as the Trials Methodology Research Partnership, ADR UK, HDR UK. So that these are just some of the examples of these sort of large national organisations who have said, okay, we're hearing this, we're listening to these challenges, we need to come together to look at how we can make this easier, both for trials, but also outside of trials as well, so for any sort of routine data research. So, but thinking in particular about trials, a few years ago, we systematically, through a Delphi study, identified the top challenges in trials arena for trials that want to use routine data. And so this is an infographic that just shows the top 7 challenges that the community felt were the most important and that we needed to address before perhaps we could start thinking about some of the other challenges that were in the list. So this was the Cormorant UK study. And I think one of the things that we learned here was that it can't all be addressed by just the trial community. You know, this is a whole trial life cycle approach. The regulators need to be involved in these discussions, data providers, data owners, you know, those holding the data trusted research environments, as well as then the actual trial community themselves. And underlying that, there is a need for ongoing public conversations to ensure that we are building and maintaining trust with the public as we continue addressing these challenges. The other thing that we sort of identified was that with some of these challenges, there is a training need as well. And so that takes us nicely onto this next slide, looking at some of the training that we've been doing in Cardiff, starting with just researchers working with administrative data, but then more recently focusing that on trials that use routine data. And so I'll be handing over to Rob in just a second. But so the centric training, just for those of you who might be trying to Google it, that's now no longer available. But what we're doing is repurposing all of that content into our later training modules, which I'm going to hand over to Rob now to talk through. Is that okay, Rob?
Yeah, great. So yeah, as Fiona says, this is kind of an area that we have become more and more interested in, kind of partly through wanting to share what we've learned. But as Fiona says, I think especially within the kind of trials arena, I think there's a kind of Venn diagram that crosses over a little bit between people who've got lots of expertise at designing good clinical trials and people who've got kind of experience of using routine data and an awareness of the challenges of that. So we've been trying to kind of bring those make those kind of circles overlap slightly more. I'll talk a little bit about some of these training modules in a moment. So we have Primerant, which we developed last year, looking at kind of public trust, how to build public trust in routine data trials. And the most recent bit of work that we've been doing, the wonderfully named TopCat, which is kind of expanding on that and offering some more training across different kind of areas within clinical trials. So yeah, this is the TopCat training program. Is part of so HDR UK have a large kind of transforming data for trials work stream at the moment, and the overarching aim of this is to kind of optimize the way that routine data is used in clinical trials to address some of those barriers that Fiona mentioned earlier. Within Cardiff, we have a role in kind of developing training offerings, essentially, mostly kind of researcher focused training, but also training we're going to be developing for kind of data owners, for regulators, and importantly, kind of public facing training as well. So the slide here gives an example of some of the areas that we're developing training on at the moment. We either have developed or we are in the process of developing. And I'll go through a couple of different areas over the next few slides then of things that we are kind of interested in looking at over the next year or two in that space. So these are some sort of topics that Fiona and I and the team have become quite interested in over the last year or so, and are developing training around, and are kind of interested in working with people on in the future. So we've got synthetic data, we'll talk about in a second. I've got data utility, using routine data to recruit into trials, and then a kind of a broad interest in involving and engaging members of the public in this type of work as well. So synthetic data, I would imagine a lot of people on this call will be aware of or will have heard of synthetic data. If you haven't, synthetic data is essentially kind of data that's based on real routine data sets, but has been kind of abstracted or scrambled in some way, retaining some of the kind of statistical properties, but reducing any kind of disclosure risk. And it's been kind of, there's several data owners across the UK have started very tentatively making synthetic data versions of their data sets available in different kind of ways. So NHS England, for example, have a synthetic version of their HES data set that is available online. You can download, anybody can go and kind of click and download that data. It has a little bit of kind of explanation about what it is, but there's no registration process. Whereas others have, I think, taken kind of a piloting approach to this and asked people to kind of register for small synthetic data versions of their data. And as a trials unit, this kind of data is actually, we can definitely see the kind of benefit of this, because Fiona mentioned kind of timelines earlier. We're often waiting for data for quite a long time when we're working in a clinical trial. Timelines can be quite tight for the overall trial. We're often working with kind of stats or health economists who may not have as much kind of direct exposure to kind of routine data sets. And so synthetic data offers a kind of, from a training perspective or from just the kind of ability to develop codes, there's a lot of benefit to us of that. So for researchers, definitely lots of benefits to this. What we were less certain of as a kind of trials community or as a wider community was the kind of public view on this. So Fiona and I were awarded some funding from ADI UK to look at public attitudes towards the use of synthetic data for research. And we've been doing some deliberative workshops with around 40 members of the UK public that have just recently concluded. And we were talking to them about, just kind of introducing the idea of synthetic data and just trying to get a sense of what people thought about its use. And arising from those workshops, we now have a set of 10 recommendations for data owners that are kind of built around, how they need to explain synthetic data to people, how they might make synthetic data kind of accessible, and the considerations around that, and how they can communicate with the public about synthetic data. So that's over the next 6 months, we're going to be kind of doing a lot of dissemination of those findings, working with data owners, and hopefully kind of influencing how they approach that going forward. And more generally, we've also got a kind of bite-sized training module on synthetic data and how that can be of benefit to kind of clinical trialists. And generally, I think this is just an area, I should say, we've been focused so far on so-called kind of low fidelity synthetic data. So this is the kind of most abstracted version of data sets that is really kind of restricted to being useful as kind of training, like a better metadata almost. But there are groups, including CPRD, who have high fidelity data sets, synthetic data sets available, which are kind of have slightly different use cases. And that's something we're definitely going to be interested in going forward as well. Another area that we've been thinking a lot about as a group here and as with colleagues in UCL, in Oxford and wider, is data utility. So in a trials context, this is essentially kind of asking the question, can routine data, can kind of healthcare data sets replace CRFs or more kind of directly collected outcomes that we use in trials? And you can imagine in clinical trials, collecting data is extremely kind of resource intensive, extremely expensive thing to do in large scale trials. So if sort of a cardiovascular outcome, for example, we would be collecting kind of direct data from participants, but also that will involve some kind of clinical adjudication, so clinicians looking over medical notes, etc. It's a very good way to collect outcomes, kind of a gold standard, but also extremely kind of resource intensive. So the question that we are kind of increasingly interested in is, can we replace some of these, or at least supplement some of these outcomes with routine data equivalents, and how can we be sure ourselves, how can we kind of convince colleagues, funders, sponsors, etc., that this kind of data is fit for purpose in that sense? So the way to do that, and the way that we are kind of encouraging people to kind of build up a library of information on this, is through data utility comparison studies called DUCs. And this is essentially where we have kind of trials that have collected this directly collected trial information, but also have an opportunity to collect alongside that kind of routine data equivalents, and then do some sort of retrospective, or in some cases prospective, comparison of those two data sources to get a sense of could we have used routine data in this study? Would that have given us kind of a similar treatment effect? Was the concordance between those two things similar enough that we could have used it? And we've developed a kind of some training modules around this, about how people do these kind of studies, encouraging people to do them, and just delivered a kind of a workshop as well in the International Trials Conference. And an area, I guess, an area that we have kind of long-standing interest in, and Fiona's done a lot of work historically in this kind of space, is how we involve the public and engage the public in these kind of conversations around routine data. And this is something, I think, when we have spoken to kind of clinical trialists in the past, this is something that they've always found to be slightly difficult, how they have these conversations with members of the public in trials that are using this type of data. So last year we put together quite a comprehensive training offering called Primerant, that was a kind of deep dive on how do we build and maintain public trust in trials that use routine data. And that was kind of going right back to basics. What are the kind of the barriers, the public barriers to the acceptability of using routine data? How do we tackle that as trialists, and how do we kind of involve and engage people meaningfully, and think about how we communicate about this kind of topic? Fiona is also, as part of that Transforming Data for Trials program, we've set up a kind of public advisory group of, I want to say 20 to 30 people, Fee, is that right? Something in that area, yeah. So members across the UK who are part of a large group, I guess kind of parallels with the SAIL consumer panel, that they kind of advising on the overall project, but they're also they're kind of a resource for us to use when we're developing training modules. So we have been having kind of separate conversations with smaller groups of this group about specific topics, about specific modules, and just getting their views on different topics. Fiona is also at the moment working on a particular training module that's kind of public facing. So I think we're kind of aware that when members of the public become involved in clinical trials as kind of lay advisors or public advisors, there are often some kind of additional barriers when there's like a routine data component to those trials. We're just trying to have a think about how we can put together some training that gives people just a bit of background that helps them kind of meaningfully contribute to those types of trials. And finally, we've also got some kind of EDI modules being developed at the moment by colleagues. So looking at the kind of considerations, if we are using routine data more and more in trials, what does that mean for kind of EDI is that in some ways that might help us kind of be more inclusive, but there are also other challenges and lots of kind of public involvement in that space too. And a final topic of interest to us. So this is something I think that we probably, as a trials unit in Cardiff at least, have had less kind of experience of doing, little bits of it, but this is something we definitely want to explore and kind of develop. And I think other trials units similarly, which is using routine data to kind of support recruitment to trials. So recruiting participants for clinical trials is a major challenge, actually, and especially in kind of large scale trials. This is often one of the reasons that kind of trials are delayed or run into troubles is just recruiting enough participants. And so I think there is a growing interest, not just in Cardiff, but wider in kind of using routine data to facilitate this part of trials, both in terms of kind of identifying eligible participants, maybe being a little bit smarter about kind of which type of sites people select, thoughts about kind of automated screening, and ultimately trying to kind of broaden trial inclusion, because we still have this issue that kind of trials are not always representative of the kind of wider population that they're aimed at improving outcomes for. And I know Fiona and Mike Robling, our co-director at CTR, were involved in some kind of consultation work last year. So the Welsh Government certainly exploring plans around how they can use kind of routine data sources to directly invite people to trials. And that there's some kind of public attitude work around that. And I think that's something that they're hoping to kind of develop over the next year or two. And that would certainly be of interest to us. And I think, again, this is just an area that we are looking to develop kind of training resources in. As I say, this is not something we've had as much experience in. So if there are people who have had experience of this, who have an interest in kind of talking about this, we'd always be very open to discussing some of those ideas with you. And just a thank you from us and a plug to certainly get in touch with us. As I say, I think a lot of this training that we've been developing, Fiona and I have some experience in these kind of areas, but we're also always working with kind of subject matter experts or people who have an interest in these topics. So if there's anything we've talked about today that you'd like to talk with us about, then our email address is there, and we'd love to hear from you. Thank you very much.